information about the stunting, the short stature. It's not just the nutrition, of course. They are some of the drugs going to affect the growth as well. It's not only nutrition in our children. This is just an example for you about estimating protein needs. You see that the younger the child is, the more protein the child going to need for kilogram of their weight. And the stress needs are sometimes, 2 times higher, or much higher. They are always much higher. And any child who going through the treatment is in stress, gonna need the stress needs. This is just a continuation. You see that adult needs only 0.8 grams of protein per kilogram, and small child needs 2.5 or up to 3. And this is how we estimate the caloric needs for children. Again, the smaller the child is, the higher caloric needs it's going to have. For example, if it's a newborn, it can be 100, up to 150 calories per kilogram. For adults, it's going to be 30 calories per kilogram. So you see the difference. Calculate something what is resting energy expenditure, and then be adding some stress factors and activity factors and growth factors. And the last goal actually is nutrition. So we have many goals before when the child is sick, and the last one is nutrition, to provide adequate macronutrients and micronutrients. The macronutrients will be carbohydrates, lipids, and protein, and the micronutrients gonna be all the vitamins and minerals what the child needs for development, and fiber and all that. So the priorities are very different than in healthy child. In healthy child, we first gonna focus on nutrition, right? To provide all the vitamins and minerals and all that. So now I'm gonna talk a little bit about nutrition intervention. What kind of option we have to intervene when the child is not able to eat. This is the Children's Oncology guidelines when we should intervene. The guidelines when we should start doing something. And that's when the child has 5% of weight loss. We also calculate the percentile of their growth. We also calculate something what is called ideal body weight for age and for gender. And if the child is less than 90% of ideal body weight, it should trigger some kind of intervention. Also, if they are less than 10th percentile for height for age, that will signify more than the child is not growing properly. Less than 10th percentile weight for age. And in some hospitals, it's not so common in developed countries, but in developing countries, the triceps skin fold and the fat and muscles are measured by anthropometry. And then, of course, we have to follow the nutrient intake. So if the child is eating less than 80% of their caloric needs for a longer period of time, that should trigger some kind of intervention. The steps in the intervention will be first is dietary advice. Just advise the caregiver how we can manage or improve the diet what the child is already eating. Then how we can modify the diet, and we add something to the diet to make it more calorically rich or higher in protein. Then there are many dietary supplements on the market. Unfortunately, the kids don't like them. Some children do, some children will, be able to drink some of those. The older children more of the appetite stimulants, and some hospitals tend to use less of appetite stimulants. In transplant, probably 90% of patients are, on some kind of appetite stimulant. Cyproheptadine is the most common appetite stimulant which we are using. It's an antihistaminicum. There are now research which is done on children with cancer, and they find out that about 75% of the children did respond to the treatment with cyproheptadine or periactine, and I think they gained like 2.5 kilograms in average in 4 weeks, but I think that's really good. It usually has no side effects. The only side effects which with high dose will be that the child is sleepy, and if the child is sleepy, you just decrease the dose. The next appetite stimulant is dronabinol or marinol. It's actually anti-emeticum, and it's pharmaceutical extract from marijuana basically, and it has a little bit more side effects because some children don't like the feeling they have after this medication, but it's works miracles for other children, especially children which has a lot of nausea, vomiting, teenagers. Teenagers can be very depressed, very nauseated during treatment, and sometimes it's really helped them. It's control their nausea, vomiting, plus it stimulates their appetite, and we use it even for children quite small. The thing is you have to start with very low dose, kind of see how the child is feeling, and then you can increase the dose. It's important that the child is able to tell you how it's feeling. So, maybe 5 years will be the age, not much younger. Sometimes if the child is already depressed, this can contribute to depression too. So, you have to watch a little bit more with this drug. The next one is megasterol acetate, megase, and that's the most potent appetite stimulant, but also it has the most side effects. So we don't like to use it as often, and the reason is it can contribute, it can cause cortisol deficiency. It should be used for short term only, but it usually works very well. But it's not used as often because of the side effect. And the next, if nothing works, we will step to nutrition support. And the preferred method is the enteral nutrition. And that's sometimes kind of hard because enteral nutrition means either tube or G-tube, and the G-tube is invasive a little bit. The tube in the stomach, it's sometimes the kids don't like it, the parents don't like it, but it really is the best preferred method of feeding the child because it's more physiological. You're using the gut, the liver, you shelter the liver. It's just better for the child. But sometimes, if the child is older, to have a tube in the nose is just so stressful for them that you have to take the aspect also in mind and kind of find the best way. But it is the preferred method of feeding children. It should be always used when the gut is working. That's our guidelines in any textbook. That's what you're gonna read, because if the gut is working, it needs to be stimulated, and it's better to feed them in the gut. But it's not always used that way in the hospital. There are different tubes. It can go through the mouth. Usually, if the child is in the ICU or intubated, it's going to be in the mouth. It can be through the nose, or it can be gastrostomy. This can be transpyloric. If the child has a lot of nausea, vomiting, it can actually go to duodenum. That will help with the nausea and vomiting because usually you can vomit. So there are different options, and also you can do most, if the child is not feeling good, not tolerating large volume, that's probably the most appropriate one to use. And there are different supplements, and we decide depending on the calorie needs, protein needs of the patient, electrolyte needs, so it depends. And parenteral nutrition is really the last step. It's sometimes used a little bit more than it should be. I have to say that in St. Jude in transplant, we use a lot of parenteral nutrition. The reason is that our children have a lot of nausea, vomiting after transplant. They have graft-versus-host disease of the gut. So many times we do partial parenteral nutrition. That's mean we don't do the lipids, but already preserve a little bit of the liver. And again, we do just 12 hours. We don't do 24 hours. That's again going to give some break to the organs. And we really push for bio-intake. What's good also that we don't have to give them all the needs through DPN, but just some calories. And when the child is on parenteral nutrition, they have to be very closely followed by the pharmacist about the electrolytes. So the reason to be on parenteral nutrition will be persistent vomiting, intracranial diarrhea, graft-versus-host disease, pneumatosis intestinalis, typhlitis, ileus, mucositis, severe mucositis, I mean in this case, or some hospital procedures. There are some new studies about the graft-versus-host disease that it's actually good to have some enteral feeds and some parenteral nutrition. Actually, if we cannot use the gut for 5 to 7 days, we have to start some kind of nutrition. That's in our guidelines. So that will contribute to the decision if we're going to start parenteral nutrition. In children which are younger than 4 years, we will not wait that long. We will try to start something earlier. The last slide, what I want to talk about is about prevention. It's hard to talk about prevention when your child is still in the treatment or just, when just finished treatment. But the truth is that the children who went through the treatment, they have higher risk for secondary malignancies. They have higher risk for heart disease. They are at higher risk for bone disease. And it's really, hard to think about it if your child went through such a, harsh treatment that you have to immediately think about, the prevention. But